Yeah.
Now I would like to continue with the same glaucoma session with a different set of renowned speakers. It is a glaucoma potpourri, and we have our chairperson as Dr. Sriram Ranglingam from Bangalore. Dr. Sati Devi will be the co-chair, and I myself will be moderating the session. We have a set of speakers, and from which we start with the first speaker, Dr. Murali Ariga. He doesn't need any introduction. Sir is alumni of Sheikh Shankara Netralaya, and he is working as a leading consultant at Tamil Nadu. And without much delay, we would like to start his talk on managing angle closure disease. We all know that medical emergency in glaucoma is one of the important thing, and angle closure is very comes top in the list, apart from Morgagnian cataracts and the intermittent cataracts, which will lead to secondary acute glaucomas. And he will deal with these different sets of angle closure systems. And over to you, Dr. Murugariga. Thank you for being part of us. Unmute, I think.
Yeah, are you able to hear me?
Yeah, you are clear.
Yeah, good morning, and thank you for the invitation to participate in this nice symposium. I've been listening to the other talks as well. Without much ado, and I will start talking on the management of primary angle closure disease. It so happened that the previous talk in the previous session was on the classification, so I'm not going to dwell much upon that. So what exactly is angle closure glaucoma? It's obviously a subtype of glaucoma that has iridotrabecular contact. So you need to have appositional or cynical closure, and the angle closure can be primary or secondary, as mentioned by the previous speaker. Who is at risk? As you get older, females have more angle closure, hyperopia, shallow anterior chamber, short axial length, thick lens, thick peripheral iris, and of course the family history of first degree relatives have a higher risk of angle closure disease. The older terminology included acute, chronic, subacute, intermittent, and so on. This was not standardized, difficult to apply, and did not correlate to the degree of damage, and did not give information about the natural cause. So we moved on to the new classification of PACS, PAC, and PACG. In PACS, you have an asymptomatic narrow angle without disc and field changes. In PAC, you have evidence of angle closure of about at least 180 degrees ITC, but no disc and field changes. In glaucoma, you have all the features of angle closure with the disc and field changes. So therefore, the management could differ depending on the spectrum of the angle closure disease. So how do we know what kind of mechanism is working in any particular situation? Is that the blockage of the trabecular measure could be caused and thought to be caused due to 4 anatomical levels of blockage. The pupillary block component is supposed to be the most common and accounts for more than 3/4 of our angle closure patients. So you need to think of the plateau iris being present. You need to think of the increased lens wall, and of course the thick peripheral iris, and mixer and multiple mechanisms can also be there. So therefore, but the starting point for managing angle closure disease remains a laser iridotomy. Most often we would end up doing a YAG-PI when we know the mechanism of angle closure is there, and we need to rule out the pupillary block component. Thereafter, we evaluate and see is there some other mechanism in addition to the angle closure primary pupillary block mechanism. The basic way of evaluating angle closure disease would be the slit lamp and the indentation gonioscope using a standard formula like Sussman, Postner, Zeiss, and so on. You need to document everything at baseline, see the peripheral anterior chamber depth. This is the primary thing which any clinician can do. A simple gonioscope and of course the slit lamp which we all have. We do have the newer technology, as the previous speaker mentioned. We do have UBMs, and we have the ASOCTs, and we have the newer biometry techniques in which you can measure the lens thickness with the biometry itself, and you can also do the automated gonioscopy available with the NIDEC new automated gonioscopy and so on. But all these are newer fancy technology and not really necessary for day-to-day practice. The UBM is useful in certain situations. The angle closure component and the lens wall, relative lens wall can be measured using this new technology and so on. We don't really know how these newer technologies and newer measurements that we get, how is it actually going to help us in our management? It's early days and we don't have normative data as well. So, but we can think of probably this could be the future of how angle closure glaucoma and management could be practiced. In the epidemiology, if you look like it's a worrying feature, that angle closure glaucoma is obviously less common than POAG in most of our studies. But you will find that the blindness due to PACG is far, far more than POAG. So therefore, it's a relatively, we call it as asymptomatic and the chronic form of angle closure glaucoma that we see in India at least. And 2/3 of these glaucomas, primary angle closure glaucoma, the Chennai glaucoma survey and the Andhra Pradesh study also have been seen by ophthalmologists and were diagnosed as open angle primarily because gonioscopy was not done. So gonioscopy remains the key for the diagnosis of angle closure disease, and you need to be teaching and you need to learn and you need to be doing much more gonioscopy than we are doing now. And also you should realize that being asymptomatic and more common in the chronic stages, the primary angle closure glaucoma may actually progress more rapidly than open angle glaucoma. These features have to be kept in mind with regards to comparison with POAG. The gonioscopy is important. We tend to miss it. It's more asymptomatic and chronic. The acute angle closures are less common in India than in other parts of the world and may progress more rapidly. Natural course of PACS, about 1/5 of the PACS may progress to PAC, and about 1/3 of the PAC may actually progress to PACG. So why this feature has been shown here in this particular slide is that we need to deal with PAC and PACG for sure, and PACS can be actually left alone for some time, at least in most situations. And we also understand that the ocular structural damage can occur with angle closure disease. Corneal endothelial cell loss, iris ischemic damage, the pupillary changes will be there, glaucoma flecken we all noticed after an acute attack, trabecular meshwork damage due to PAS formation, and of course the optic neuropathy due to acute elevation of the IOP can cause ischemic pallor of the disc when there's an acute elevation. And the slow and chronic elevation of the IOP results in the typical optic nerve damage of glaucoma. So these are all the features very typical of chronic angle closure glaucoma. You have the optic disc changes, you have the PAS here, and you have the typical pupillary changes with the atrophy of the iris and so on. So PACS, as somebody has mentioned in the previous talk, that is asymptomatic narrow angle. You treat selectively when the patient can't come for follow-up. You need to dilate periodically. Patient is from a remote area and so on. PAC, all primary angle closures, regardless of the status of the disc and field, you should treat with the YAG-PA and follow up this patient. Primary angle closure glaucoma, start off with the YAG-PA, follow up the patient for IOP, and definitely monitor the disc and the field. In the management guidelines of angle closure disease, what we usually suggest is that you should assess the extent of the residual angle closure after the YAG-PA is done by dynamic gonioscopy. After the YAG-PA, definitely do gonioscopy. Establish baseline features after the YAG-PA, look at the optic disc and the visual field, and this becomes a new baseline. Follow up for progression of angle closure, looking at the intraocular pressure, the gonio findings at least annually. Look at the optic disc and fields like you do for any other glaucoma. And mind you, the education of family members and siblings regarding the risk of developing glaucoma in the family, especially with regards to angle closure disease, is very, very important. So medical therapy, many patients after assuming a successful YAG-PA, which we release only the pupillary block, but other mechanisms like plateauvirus and other features could be there, which results in elevated IOP. So topical glaucoma medication would have similar efficacy in angle closure as well. So therefore, don't hesitate to treat after the YAG-PA and control the IOP adequately. What are the surgical options when you have very high presenting IOP of more than 30 and more than 180 degrees of PAS, the long-standing optic nerve damage, moderate to severe? A laser iridotomy is obviously not likely to control the IOP adequately, and trabeculectomy is indicated. If there are significant lens changes, a combined surgery of cataract with glaucoma has to be thought of. But mind you, in angle closure glaucomas, we all know the dread of facing shallow ACs post-operatively, uveal effusions, malignant glaucoma, and cataract formation if we're doing only TRAB. And this is much more than an open angle glaucoma because the AC is shallower than in POAG. So all these features and problems have to be kept in mind when dealing with primary angle closure, but angle closure glaucoma, particularly when you're doing trabeculectomy alone. And I'll show you a short video clip of how I do. This is a relatively old video in which I have done a separate site trabeculectomy with cataract surgery. I usually do the trabeculectomy flap first, partial thickness flap of about 4 mm triangle, and the phaco is done in the usual way. And this is the clay cornea phaco, and the cataract surgery proceeds as usual. And you will find that the phaco, we need to look at the endothelium a little more carefully because the patient had chronic angle closure glaucoma and long-standing glaucoma. You could also expect a lower endothelial cell count, so take care that you don't you protect the endothelium adequately when you're doing the cataract surgery. And the cataract surgery itself would deepen the anterior chamber sufficiently, at least by a significant amount to open the angle. And after the lens is in the bag, make sure the lens is in the bag as far as possible. And after the phaco is done, And this is the way I do the trabeculectomy. There's so many other methods, of course, and this is one simple method. I use the Kelly sponge, and an opening of about 1.5 to maybe even 2 millimeters punch is made, and the iridectomy is done adequately so as to make sure there's no pupillary block component, as well as the ostium is not blocked. I usually take one apex releasable suture most of the time. This is how I apply the releasable suture. You can see the 10-0 nylon releasable suture. Mitomycin can be also used, and I also sometimes use Ologen. And this is how the clay cornea phaco incision also sutures, so that there is no leakage from the wound. And I also have another video clip, a short clip if time permits, of the same site phaco with trap. This is again an older video in which I have used Ologen. And this proceeds with phaco and IA and the IOL implantation. And after the IOL is implanted, and what I usually do is I open up this scleral tunnel a bit. And this is one method. There's so many other methods. Even without opening the scleral tunnel, you could do the trap. But this actually makes the visualization easier. And here you have the internal cataract wound, and you make another incision just behind the cataract incision. And with this opening, you can actually do the trabeculectomy through that, the scleral opening, and do the iridectomy through that. And following this, you can actually suture the incision. And in this particular case, I have actually used Ologen after the sutures are applied. This is how the ostium looks like after the sclerotomy is made. Suture, and then place the Ologen as far posterior as possible. So there has been some controversy regarding the removal of the natural lens, and this has become fashionable in certain countries and certain practices. That the Eagle study is quoted quite often, and the Eagle study actually looked at the standard method of dealing with angle closure glaucoma, and also the what we call as the clear lens extraction was considered, and found this particular study found that the mean IOP was slightly lower after clear lens extraction as compared to the standard of care. The study had various drawbacks, and the results cannot be extrapolated to the treatment of PSC or PSC in the clinical scenario. Younger patients less than 50 years of age will lose their ability to accommodate when the clear lens is removed. The extent of glaucomatous damage in this particular study was limited to very early glaucomas. The range of moderate glaucomas is much lower than the range of damage seen in our population. Gonioscopy data was missing in large 58 to 60% of the population in the study. The difference in IOP between the two groups was very minimal, and the quality of measure, which they say was better in the CLE group, was actually reflecting the correction of refractive error in the clear lens extraction group. So therefore, my take-home messages in this talk would be that PSCG is an important cause of blindness, and most cases remain asymptomatic. So make sure gonioscopy is vital, and keep doing gonioscopy. Newer technologies will assist us, will assist the clinician, but cannot replace the simple gonioscopy. Laser iridotomy is the first initial step for managing angle closure glaucoma. After the iridotomy, IOP must be controlled medically, either with and by laser and surgical means. Clear lens extraction is clearly a controversial, debatable topic, and not for all. If fellow eye management is vital, you need to do a prophylaxis for the other eye. Counsel patients regarding the disease and emphasize the need for regular and long-term follow-up, and advise family members to undergo screening. The acute attacks, as I already mentioned, are relatively less common in our populations. I have not dwelt much upon the acute attack, and we all know how the management of acute attack is, with the immediate acute pressure reduction with intravenous mannitol, topical medication. The only point I would like to stress upon is that in the acute management of acute angle closure, do not put the intensive application of drops like we used to do in the past of half-hourly, 1 hourly, 2 hourly pilocarpine and so on. You could manage with mannitol, manage with a little bit of topical steroid and the glaucoma medication. And don't be in a hurry to do the YAG-PI immediately in the first day or the second day or third day after the attack. Wait for the eye to quieten down, and then you can do the YAG-PI. This is my take-home messages for the angle closure glaucoma.
Yeah, thank you, Dr. Murali. It was a wonderful presentation. You really opened up our minds as well as the angles also. And I also welcome for those who are joined late, maybe Dr. Sriram Ramlingam, Dr. Sati is our co-chair, Sriram is our chairman. And I also welcome Dr. Devang from Delhi and Dr. Vikram, of course. Just one or two quick questions so that we'll move on to the others. So all the other previous speakers also can stay back to contribute. So in the end, we can have some delayed discussion or a detailed discussion. So, Dr. Modi sir, what like you use what type of gonioscope? Because gonioscopy is a very important part of angular closure, and how frequently you do it? Because the angles which were almost open may tend to become closed or narrow over a period of time due to lens change and so many other issues. So, how frequently you will recommend for the audience to do gonioscopy?
Excellent question, Shailesh. I think my choice for gonio lens would be the Sussman 4 mirror without the handle and without a flange. And I also have the other ones like the Postner with the handle. I have the Zeiss with the 4 mirror and so on. But my favorite is the Sussman type of 4 mirror lens and without the flange and without the handle. And secondly, your question about gonioscopy, of course, at diagnosis, you would do the gonioscopy for sure, document everything. You don't need pictures, even a clinician's notes would be good enough. And the other thing is, whenever any intervention is done, like surgery or a YAG PI or some method of intervention has been done, like cataract surgery has been done, then the baseline changes. You need to document everything again. And thereafter, for the patient's life, at least an annual gonioscopy is mandatory.
Okay. I saw your Ologen placement. It is said to be slightly on the bleb or on the scleral suture itself. Is there any reason why you have to place more posterior?
Actually, frankly speaking, this is an older video, and I actually stopped using Ologen for more than a year now. Ologen is no longer available, and it's very, very expensive now. So I think
available.
I don't really, yeah,
available but expensive, of course.
Because your question of placing the Ologen, I keep it posterior because invariably there is a slide of the Ologen to the anterior part after the surgery is done. Invariably, most of my Ologens tend to come forward and sit on the flap itself. That's why I used to keep it posterior, and because the loosely kept suture and the tendency to slide forward, I usually tend to keep it behind the flap, behind the Adherence.
That's a good idea. Any other important quick 1 or 2 questions? We'll move on to the next speaker. Okay, and now we will go to the next speaker, our chairperson, Dr. Sriram Ramlingam. He is a very senior consultant from Bangalore. Sir will be speaking on anti-glaucoma medications, how to select. There are so many array of medications, and he will just throw light on how to select one of them or all of them. Now over to Dr. Sriram, sir.
Can you play my video? It's already there, no? Can you play the video?
Yeah, Saujanya, please play.
Yes, doctor. Sharing.
Hello. At the outset, I would like to thank the organizers, Dr. Ellen Kumar, for this opportunity. I will be speaking about medical management of glaucoma. As everybody knows, glaucoma is a multifactorial disease of which intraocular pressure is the only modifiable factor. Our treatment is aimed in decreasing the IOP to a level that will slow the progression of the disease. As all of us know, the glaucoma is a silent thief of sight. The symptom starts only when you start the patient on treatment. The goal of the treatment is to maintain the patient's visual function for the rest of his life with a good quality of life at a sustainable cost. This is a very good chart which shows whom do we need to treat. Patients, the category of C, that is younger patient diagnosed early in life with moderate rate of progression, or patients in the category C who have got young patients, rapidly progression. These patients we need to treat aggressively. What is this rate of progression? It's very important to assess the rate of progression. Rate of progression will determine the target IOP and hence the treatment options. Our goal is to decrease the rate of progression. The rate of progression in primary open-angle glaucoma differs very much between persons, rapid, moderate, or slow. Hence, it is necessary to determine the rate of progression in patients with manifest glaucoma. How do you determine rate of progression? Is basically by visual fields. European Glaucoma Society recommends 3 visual field tests per year for the first 2 years after diagnosis to identify these patients, how they are progressing. After 2 years of perimetric monitoring without progression being detected, the frequency of tests can be decreased. Treatment. As all of us know, the intraocular pressure is the only modifiable factors. What are the other factors? When we are not aware of it, but other possible treatment that have been investigated includes ocular blood flow and neuroprotection. We hear a lot about target IOP. What is this target IOP? The target intraocular pressure is the upper limit of the intraocular pressure, which decreases sufficiently the rate of progression to maintain a vision-related quality of life in the expected lifetime. It is not a single IOP reading, it's a range. It differs from person to person, hence target IOP should be individualized. It's a dynamic process. The target IOP is set. When is the patient still progressing, then we need to recalculate the target IOP. What are the factors that affect target IOP? It depends upon the glaucoma damage. Is it early or late? The life expectancy of the person. What is the untreated IOP? Is it high or low? Additional risk factors, one of them is central corneal thickness and the rate of progression. All this will determine the target IOP. Now, based on the disc and the visual fields, glaucoma has been classified into early, moderate, or advanced. The target IOP will depend upon the stage of the glaucoma. That is, in early glaucoma, one expects a 20% reduction from the baseline or the IOP less than 21. Moderate glaucoma, so intraocular pressure less than 18 or 30% reduction. In advanced glaucoma, the IOP less than 14. The target IOP is based on the disease stage and the intraocular pressure to begin with. And additional risk factors are added to that. All the various trials that were done, all of them show, by decreasing the intraocular pressure, you are decreasing by half or more than half the rate of progression. All these various studies say the same. Before we put the patient on medication, one needs to know the patient characteristics and the drug properties. What is the clinical picture of the patient? What are the ocular and systemic risk factors for this person? Will the person be able to adhere to the medication that you are prescribing? What is the type of job is he doing? How long does he work? Will he be able to use the drops? And what is the quality of life? About the medication, one should know the mechanism of action of the medicine. What is the efficacy on the target IOP? Is it a preserved or unpreserved? Or what is the cost of the treatment? Now, before putting the patient on treatment, one should know about the medications which are available, plus what are the indications or contraindications. Like beta blockers is contraindicated in patients with asthma or heart blocks. Carbonic anhydrase inhibitors should be avoided in patients with low corneal endothelial count. Our systemic carbonic anhydrase inhibitors are better avoided in patients with sulfur allergy or patients with kidney problems. Alpha-adrenergic agonists usually do not have any contraindication, but they cause severe allergic blepharoconjunctivitis. Prostaglandins better avoided in patients with pseudophobia who have had complications or uveitic glaucoma. Now, before, it's always, when you start the treatment, it's better to put the patient on monotherapy. When you start a monotherapy, one should know what is the target IOP that you want to achieve. So based on that, you will start a medication. Like prostaglandin gives around 20 to 35% reduction in the intraocular pressure. Non-selective beta blockers gives around 20 to 25% reduction. Alpha-adrenergic agonist gives 15 to 20% reduction in the intraocular pressure. Selective beta blockers gives around 15 to 20%. Lastly, topical carbonic anhydrase gives around 20% reduction in the intraocular pressure. So treatment depends upon the baseline intraocular pressure. With large reduction is possible in patients with higher pre-treatment IOP. At low intraocular pressure values, medical or laser treatment have a small effect on the intraocular pressure. Once you have started the patient on treatment, and it is well tolerated, and the target intraocular pressure has been achieved, the medication is left unchanged, but the patient needs to be regularly followed up and to monitor for any change in the intraocular pressure or change in the progression. Here I talk something about the uniocular drug trials. As everybody knows, intraocular pressure fluctuates throughout the day. So one is not sure whether your medication is effective or you're assessing the IOP fluctuation. So this uniocular drug trials helps us in this. But uniocular drug trial is not always feasible or always logically feasible because of the very high intraocular pressure to begin with or in advanced disease state. But if one desires to put the patient on uniocular drug trial, one should know that when you assess the patient, it takes like beta blockers, alpha-adrenergic agonist, and carbonic anhydrase 3 to 4 weeks before we reassess the patient. Prostaglandin analog may take up to 6 weeks to achieve the maximum effect. Myotics may take a few days. If the monotherapy what you are put in is not effective, switch to another monotherapy. It's better to change the medication, even if the medication is prostaglandin analogs, when used as the first choice. There are some not responded to certain prostaglandin analogs. One can switch to another class of prostaglandin analogs, which may be beneficial. So once we switch the patient on prostaglandin to another class of drugs, we should know what is the washout period. It takes 3 days for the pyrrolocarbon to wash out from the body. It takes 1 week for carbonic anhydrase inhibitors. It takes 4 weeks for the beta blockers to wash out from our body, and it takes up to 5 weeks for alpha adrenergic agonists, or it takes 8 weeks for prostaglandin analogs to wash out from our body. So one should reassess the patient after the washout of the medication. Here's an important thing one should remember about compliance and adherence. Before switching, it's important to assess whether the patient is compliant enough to use the medication adhering to the treatment. Many times there's something called as a white coat compliances. That is, the patient may be progressing and you may be surprised to know the intraocular pressure has reached the target IOP. This may be because of what is called as a white coat compliance, where the patient uses the medication on the day or a few days before the appointment checkup. If the first medication after switching the medication is still not achieving a target IOP, it's better to add another medication. Adding a medication, a second drug should be considered always. While selecting the second medication, it should have an additive effect to the first one. It should be safe. The frequency of dosing should be good enough for the patient to use it, and combining agents with different mode of action is always better. Multiple topical treatment have a problem of adherence. It increases the exposure to preservatives. So fixed dose combinations are always used or beneficial to the patient. There's a very good flow chart which shows you how do you go about the treatment. First choice is monotherapy. If it reaches the target IOP and is well to prevent the progression, continue the same but monitor the patient. If insufficient intraocular production reduction or visual function is not achieved, switch the monotherapy. If the switch monotherapy if the target IOP is reached, continue the same. If after switching still the target IOP is not effective, then you add another treatment. The target IOP is reached, then you can monitor the progression. But even after this, if a target intraocular pressure is not reached, then one should consider other modalities of treatment like surgery or lasers. Now, once you're achieved your target IOP, then re-evaluate the patient for progression. A progression does not occur, patient is stable, progression does not occur, follow up the patient. If there's still a progression, consider lower target IOP, try to achieve by other means by adding another medication or considering surgery or considering lasers. If it is stable, continue the follow-up of these patients. Newer medications that have been available recently has been the kinase inhibitors. Their mechanism of action is basically increasing the trabecular flow or decreasing the aqueous production and decreasing the episcleral venous pressure. It takes at least 6 weeks for the full effect to be seen. The main side effect of these medications is hyperemia and cornea verticillata, very rarely seen. But the two classes of medication, ripasudil and netasudil. But this is usually, and netasudil is available as a combination with latanoprost. I use this medication as a second line of treatment. I don't start the patient on first line of treatment. Next, coming to the important topic of medical management of glaucoma during pregnancy. It's very important to discuss with the patient the risk of medication during pregnancy because of the organogenesis can be hampered and can lead to birth defects. It's very important to discuss completely with the patients what are the problems of the medication. As the first trimester of pregnancy, brimonidine tartrate is a class category B drug, is the safest of the lot. Beta blockers, prostaglandin analogs, and carbonic anhydrase inhibitors should be avoided as much as possible. Avoid surgery in the first trimester. Second trimester, one can add beta blockers along with brimonidine tartrate, but one need to regularly monitor the fetal heart rate and fetal growth monitoring. If prostaglandin analogs are added, one should look for premature labor. When topical or carbonic anhydrase inhibitors are used, fetal growth retardations have been known. In third trimester, brimonidine, beta blockers, or topical carbonic anhydrase can be used. Prostaglandin analogs should not be used, which can lead to premature labor. In the late and third trimester, it's better to stop brimonidine, which it can lead to central nervous system depression in newborns. topical carbonic anhydrase inhibitors can be the optimal choice. During the postpartum period, carbonic anhydrase inhibitors and beta blockers are considered to be safe. However, low dose of this medication should be considered when there is a breastfeeding period. Brimonidine is contraindicated in these patients. In conclusion, assess each patient individually when deciding the most appropriate treatment. It is essential to involve the patients as informed career partners in decision regarding the management of their conditions. The least amount of medication and least amount of medication and the cost is very important, along with the side effect, to achieve the therapeutic response. A therapeutic trial wherever possible should be tried. Usually there is no need to start the medication immediately once you diagnose until all the baseline diagnostic data are collected, unless the IOP is very high and very severe damage. After diagnosis, it's advisable to measure the untreated IOP more than once before initiating the treatment. Thanks for your patient hearing.
Thank you, sir. Thank you, sir. It's a very elaborate and a very useful talk on the anti-glaucoma medications, how to use it. You came up with a very interesting phrase like white coat compliance. The patients tends to use these drugs before coming, but in some situations we see patients come stopping the medication 1 day, 2 days before, telling that doctor, anyhow we are coming to meet you. We thought you might change the drug, so we have come without putting the drops.
That is also so that is also there. So we come back to the square one again. Whether the medicine is effective or not, we don't know. Also we get a lot of patients. The bottle is getting over now. So should I buy the new medicine or not? That question is always comes in the patient's mind. Yes.
Exactly. That is one thing. And before starting any cataract surgery, would you like to stop or modify any anti-glaucoma medications? One question is being asked. Especially
only for cataract surgery, I don't think I will stop unless you are going to combine the medication or say going to do a combined surgery. But sometimes I stop the prostaglandin analogs because it causes some amount of inflammation. Maybe 3-4 days or a week, I stop the anti-glaucoma medication, prostaglandins. I usually put all my patients, glaucoma patients who are on medications, on topical antibiotic plus steroid before I take the patient off for cataract surgery.
Okay. Any change in perception, Dr. Murli, Dr. Sati Devi, please, on stopping any medication before cataract surgery?
No, the same thing. I also like to stop the prostaglandin analogs. I stop it both for cataract and combined surgery. I generally like to stop same thing 1 or 2 weeks prior to surgery. I like to stop it.
Yeah, I also stop PG analogs a week prior. Dr. Murli?
I don't stop prostaglandin. In fact, I use it even up to the previous day of the surgery, and I don't stop it at all. And only post-op I stop it. And in case a glaucoma medication needs to be applied post-op, I would not use a PG analog for about a few weeks. But pre-op, I don't stop at all. If the patient has been on glaucoma medication for a long time, chronic therapy, then we worry about the conjunctival surface, ocular surface. So therefore, using FML type of steroid or even a stronger steroid preoperatively to sort of quieten the inflammation preoperatively and so-called help the bleb form well is what some of us do. But we don't really know which is the correct answer.
Yeah, true. Now we can keep questions for the end of the session. Now let us move on to the next topic by Dr. Devang Angmo. She is a dynamic consultant at RP Center, AIMS, Delhi, assistant associate professor doing a lot of research work, and she will be throwing a lot of light on lasers in glaucoma. Dr. Devang, please.
Yes, sir. Dr. Shailesh, are my slides visible?
Visible. Just make a full screen, please.
Yes, I'm putting on to the PowerPoint mode.
Yeah.
Thank you, COSCON. Thank COSCON for the invite. I would be speaking on lasers in glaucoma, and so since this is a basically bit for glaucoma, we have medical as well as surgical therapy, and lasers, they form an important bridging gap between the two. And this is being a vast topic. I would like to first give an outline of the same. We have lasers for angle closure glaucoma. We have SLT. Then we have lasers in the refractory glaucoma, and we have newer lasers in our armamentarium now. And we also use lasers for the early post-operative glaucoma management as well. So coming on to lasers for angle closure glaucoma, as we are all aware, we have laser iridotomy as well as laser iridoplasty. Coming on to laser iridotomy, we initially pre-medicate our patients with pilocarpine 2% and do it under topical medication. Important thing to note is that we use a laser power for around 2 to 6 millijoules, and usually our eyes we usually need 2 to 3 spots if done in the proper positioning. So basically we use an Abraham lens, which is a contact plus 66 diopter lens, and we prefer the peripheral superior area where there are thinning of the iris, where basically the iris crypt area. And we the patients post laser are put on topical antibiotic steroid along with the continued anti-glaucoma medications, and they are followed up at 1 hour, 1 week, and 4 weeks. So, and second I would like to speak about is the laser iridoplasty. The important thing is that this is mainly indicated in cases of where the peripheral, there's a thick peripheral iris roll like in plateau iris, or cases where in angle closure where the iris is very thick. So usually we need 20 to 30 spots of the argon laser with a setting of 300 to 500 milliwatt and a duration of 300 to 500 milliseconds. And normally the peripheral iris is just flattened and the angles open up. Then we have the SLT, that is a laser trabeculoplasty. This is basically a double frequency switched YAG-Q switched laser, wherein a 400 micron spot 0.8 to 1 millijoules energy is used, and we use a 50 spots over 180 degrees in one setting, and we can also repeat the same in the opposite angle if the required IOP control is not achieved. So SLT is now being preferred because the amount of energy is nearly less than 1%, and that's why the side effect profile of SLT is much lesser, and therefore the thermal damage is also not there. So SLT, we again continue the patients post-operatively using NSAIDs along with continuing the anti-glaucoma medications, and they are tapered gradually as the target IOP is achieved. And again, they are followed up at 1 hour to see the IOP spike, then at 1 week, 4 weeks, and thereafter at 3 monthly interval. Next, I would be coming on to lasers in refractory glaucoma. So we have the standard contact DLCP, which is the diode laser cyclophotocoagulation. Then we have the newer lasers like micropulse and endoscopic cyclophotocoagulation. So I would be discussing them one by one. So in the DLCP, that is the diode laser cyclophotocoagulation, the standard energy protocol that is being used is 1500. We start with 1500 to 2000 milliwatt for a duration of 200 milliseconds, 2000 milliseconds. And I'll just be showing a small video. So I think the video is. So just
press on the image maybe.
Can you see the video now?
No. Only slide is.
Okay, in my thing, the video is running. Okay, so I'll just explain. So basically, this is the G probe which is there. So which is placed over the ciliary body, and using the same parameters.
Come to full screen.
Yeah. So I think the video is not. So this is the G probe which is put over the limbus, and then the laser settings are put, and then we just move the laser probe over 180 to 270 degrees to see the desired effect. Then we have the newer lasers, which we have endoscopic cyclophotocoagulation and the micropulse. So this is the endoscopic cyclophotocoagulation setup, where this is the monitor, this is the laser control unit. And what we normally do is we usually go through the limbal route, the anterior route, and we fill the anterior sulcus, preferably in a pseudophakic patients, we fill the anterior sulcus with a high viscosity viscoelastic like Helon GV. And then we put our laser endoscope.
Dr. Devang, this video is playing on your computer. I suppose that audio is being heard.
But the video is not visible.
I think it is open in some other window. Maybe we have to close it.
That's what.
Or mute that video, because there are two sound voice and we can hear.
Okay, I'll just.
I think it is playing somewhere in your system.
Now I've switched it off.
Yeah.
Okay, so should I just repeat the previous one then?
Yeah, we could hear,
should I move on?
There was overlapping of sound. That's all.
Okay.
Yeah.
So just to again make it clear that in diode laser cyclophotocoagulation, we use the laser power of between 1500 to 2000 milliwatt and to with a duration of 2000 milliseconds, and we put the G probe over the limbus, and then we gradually sweep, or we gradually move the probe to 180 to 270 degree to have the desired effect. So nowadays we have the endoscopic as well as the micropulse laser, which have come into the armamentarium. So the endoscopic cyclophotocoagulation, this is the entire machine. The top monitor is basically the video display where you can see the laser being done. The lower down we have the control unit where we can set our laser settings. So we preferably do through the anterior limbal route, and we select patients who we are combining either with phaco along with ECP, or pseudophakic patients or aphakic patients. And we fill the sulcus with a high viscosity viscoelastic like Helon, and then we enter with our probe, and then each ciliary processes are cyclophotocoagulated. So this video of ECP, is this visible? I've put a video.
Video part is not visible. Video part is not
visible again.
Slide is visible.
Okay, so
maybe you can close down. If time permits, you can separately play the video.
Yeah, then I'll just, because so basically we just then through this I'll just explain that then once we fill the sulcus with the high viscosity viscoelastic, then we put our endoscope, and with the aiming beam we aim to the ciliary process, which are usually seen like finger-like projections, pigmented. And once we start our laser, we can see the endpoint as whitening of the ciliary processes along with the shrinkage. Then we come to know that the laser is complete. And in that sweeping mode, we just complete the entire 180 to 270 degrees, whichever we have planned for, to have the desired effect. So if we look at the outcomes of endocyclophotocoagulation, so in a study where phaco along with ECP was done and phaco alone, it was shown that at 3 years, the IOP reduction was much more along with phaco ECP, and the number of medications also was definitely lower in cases of phaco ECP. And looking at the safety profile, we have seen that ECP is having a very low incidence of complications, and hence can be done in eyes with having good vision potential. So next we have the Micropulse Laser system. Again, I'll just run this short video. So basically now is this video visible?
Yeah.
This is the Micropulse laser system. Here we use the 2000 milliwatt of energy only for 90 seconds. So here again a G probe is put at the limbus, similar to that of a diode laser, a DLCP. But here we are just sweeping the laser probe, wherein in the DLCP we have to just lift the laser, put it again at adjacent. Here we can just see sweeping movements. First we do the inferior 180 degrees, and then we do the superior 180 degree. Leaving the nasal and the temporal parts where the ciliary vessels and nerves are there. So once it is complete, it's basically for 90 seconds. Once it is complete, after 90 seconds, then we follow up the patient. So if you look at the outcomes of micropulse, because the theory behind micropulse, or the why the micropulse was developed, is because the amount of damage that was happening after DLCP. That's why this new micropulse laser was had come into vogue, because the cycle duration of the laser itself, although the power being 2000 milliwatt itself, but the cycle duration is only 1/3 time when the laser is on. The rest of the time, 2/3 time, the laser is off. So the amount of damage or the side effect profile has definitely lowered while using the same laser power. So if you look at the long-term outcomes, it has shown that micropulse can be considered in early management of glaucoma, especially in patients having a good central vision. Next we come on to the class laser, which is the carbon dioxide laser assisted deep sclerectomy, which is basically being used in cases where non-penetrating deep sclerectomy surgeries are done. After lifting a triangular flap, as we do for a trap, the class 2 laser is put, and the deep sclerectomy is done. Thereafter, we can just suture the flaps and get the desired outcomes. So the class, if you look at the class CO2 laser ablation system, it allows precise and easy creation of the scleral flap and ablation of the Strem's canal. And this technique has shown to be more efficient than the standard NPDS surgery in terms of IOP lowering effect at nearly 1 and 2 years of follow-up. Then the most important thing that we also know is that we can use lasers in the post-operative glaucoma management. So firstly, we can use it for laser suturolysis, where we can use an Nd:YAG laser with the following settings. So this most of us have encountered that we have done our trabeculectomy, and now the patient has come with the high pressures and the bleb is flat in the early post-operative week, and as we do a bleb massage, the bleb tends to raise. However, this is not consistent. So that's why what we do, we can see here, we have made a triangular flap, and we can see the suture is being tight. So we put a Hoskins lens over it and just do a single spot laser. We can see there's a nick here, and as the laser is done and we just massage the bleb, we can see that the bleb has elevated, and now the IOP has further decreased. And when we keep the patient on follow-up, the bleb has basically, it is functional and it is maintained, and we get away with the patient being shifted to the OR and having other complications if we try and open the bleb in the OR. So we can also have patients who have avascular bleb presenting with chronic hypotony. Here we can try and laser the bleb by using a gentian violet dye, which we stain the bleb surface. And once basically this dye helps and absorb the laser and enhance the laser absorption. So we use the Nd:YAG laser. So this is one patient who had presented during the COVID time, and she was having a cardiac history and was not very willing for to get a bleb remodeling surgery. We did a bleb laser, and the IOP from around, she always presented with less than 6. Now the patient is following up at IOPs of 12 to 14 mm mercuries, and the vision also has improved over the time. We can also have patients, which is the biggest nightmare for glaucoma surgeons, having patients with malignant glaucoma, wherein we can use laser for the management without doing any surgical intervention. So here we can either do a laser cyclophotocoagulation of the ciliary processes, which can cause shrinkage of the ciliary processes, or we can do a laser YAG capsulotomy or a hyalotomy to break the aqueous misdirection and enhance the and form a conduit between the posterior and the anterior chamber. Then we can also use a laser for syneculysis. So this was a case wherein a patient came on the first post-operative day after rubbing his eyes. So we have done a trabeculectomy. The entire iris has plugged in. So now and also the iris was shallow. So we didn't want to enter the patient, and we just put a single Nd:YAG laser spot, which just disrupted the iris posteriorly, and we followed the patient up. And now after a week, we can see that the iris has fallen back. The pupil has also become now slightly towards roundish, and the bleb is also functional without any blockage. So this is an interesting case wherein a patient came after a post-traumatic implantation cyst, and the patient had a IOP between 26 to 28 millimeters of mercury. So we were initially skeptical, and he had a vision of 6.6 in this patient. So we were skeptical whether to operate or not. So we attempted doing a laser, and now patient is at around 6 months of follow-up. The cyst has still not recurred, and the patient is following well with the IOP between 12 to 14 millimeters of mercury. So at the end, I would like to highlight that lasers have an important role in the glaucoma management, which is bridging the gap between the medical and surgical therapy. Newer lasers having a lesser power or a duty cycle, therefore having lower side effects may be considered, but the cost benefit ratio should be taken into account, and they are definitely safer alternatives for a glaucoma surgeon. Thank you.
Yeah, thank you, Dr. Devang. It was a wonderful and elaborate presentation on lasers. A very quick, small question is that you do ECP as well as micropulse. I mean, almost
Yes.
similar indications. Is there any overlapping of indications, or which one fares better over the other?
So normally, basically, if we are doing a phaco, especially if we are doing a phaco and the patients require any other procedure, so we can do phaco with ECP, or patients with specifically which we are doing as patients who are operated via surgery, who have silicone oil, along, and so micropulse per se doesn't have a very good effect. So we are doing ECP in those patients, and we are getting a good effect in those patients.
And regarding micropulse per se, where do you really use it, and what is your experience at RP Center?
So in micropulse, again, we have always kept it as a not as a primary line. We have kept it as a second. Once we are, getting a surgery done and still the IOPs are not getting controlled in that, and patient does have a good IOP control, especially in cases of who have failed trab and who have come back. Now they have good vision, and we want to still consider them. So we have given micropulse in them also, and although we are not getting it has a very short-term effect, doesn't have a very long-term effect, so it is just a temporizing effect. We can give the patient and secondly, also in cases where patients is waiting for the IOP to get controlled and waiting for some second surgery. So once the IOP is controlled, they can get the second surgery done, especially VR surgery or a cornea transplant, and then we can do our glaucoma surgery subsequently if required, tube or anything. That can be planned also in a stage manner.
Okay, thank you. Any other thoughts on micropulse, Dr. Murali? You have been also doing it.
Yeah, I think I differ slightly with Dr. Devang that the effect is short term. I think we have a follow up, and we have published our data of Indian eyes, about 55 patients with the micropulse in Springer of Cell a few months ago. And our experience has been when done well and when done with the correct application, the sweep time, the duration, the dwell time, everything is important. There's a learning curve, and it does tend to last in the average patient for at least about 2 years. We now have follow up for even 3 years now. That is one. And the second thing is, of course, you would avoid inflammatory eyes, and also primarily I would avoid doing it post traps, post tubes, post PK. Particularly, it works quite well. And I think the 90-second thing is a bit too much. Probably I would go for 80 seconds, like unlike what she has shown about 90 seconds. I would do 80 seconds, and I sometimes do a repeat inferior alone. I would do one more, and we have a different method of each quadrant where application. So many different techniques of application. So I think the technique and the sweep duration and the pressure which you apply can go a long way in having a different outcome.
Yeah, thank you. Can you please unshare Dr. Devang? Thank you very much. Next, I will be speaking on.
Yes, sir, I'm just doing it.
Because we are running about 10 to 15 minutes late.
Yeah.
So let us keep questions at the end. Can you see my screen?
Yes, sir.
Yes, doctor.
Okay. Yeah. My topic is on ocular hypertension, when to treat. So we all know the definition is that IOP more than 21 millimeter on 2 occasions where there is no detectable visual field loss, no detectable optic disc or RNFL damage, and the angles are open, as well as there are no ocular or systemic cause of increased IOP. Now, in a case here, we have a 45 years male with IOP of 26, CCT of 580, CDR 0.5, and visual fields are normal. So what could be the diagnosis here? It usually classically fits into our ocular hypertension scenario. And we have raised IOP, normal disc, normal fields, to treat or not to treat. So we have a glaucoma continuum where we have a normal range here and the advanced glaucoma with blindness. So this ocular hypertension fits into this first half of the continuum where we cannot detect the glaucoma process because it remains asymptomatic, and also many tests are not going to detect the glaucoma procedure. So a lot of trials have been done to address these questions, right from the ocular hypertension, the basic on the starting point, and then the advanced glaucoma intervention studies. And they have come up with 2 studies. One is OHTS and European Glaucoma Prevention Study to address the ocular hypertension problem. And the purpose of this OHTS study was to treat or to observe and to look into the conversion rate to open angle glaucomas and to find out the risk factors for progression. They randomized 1,636 patients into observation handle and a medication handle. And they found that the risk factors of age, every 10 years increase in age, 22% relative risk of developing glaucoma. IOP of 1 millimeter increase or 10% risk, and a corneal thickness of 40 microns, a reduction, that is thinner corneas have 71% risk. Horizontal CD ratio of 0.1 increase has got 27%, and a vertical CD ratio of 0.1 increase has a higher 32%. So vertical CD ratio is quite important, and a PST on visual fields 0.2 decibel increase is subjected to 27% changes in the development of glaucoma. And what are the clinical relevance? So 90% of ocular hypertensions did not convert in 5 years in their study, and the treatment is effective, and definitely of 10%, half would have been prevented. So that's why they went in for the second handle, where they even treated those patients who are beyond 5 years. CCT to be done before treatment, because some drugs can also modify the central corneal thickness. Not every patient of ocular hypertension should be treated. And the moderate to high risk, definitely we have to treat them. And low risk, no treatment, because 90% did not convert in their trial. So they also come up with risk factors which are involved in conversion of glaucoma, ocular risk factors and systemic risk factors. In the ocular risk factors, we have height of the IOP. The increase in the IOP, higher the IOP in the baseline, higher the chance of developing glaucoma in the coming years. Large vertical CD ratio, CD asymmetry of more than 0.2, then a previous history of any disc hemorrhage without any morphological changes in the disc, RNFL defect in the absence of ONH changes, and a thinner CCTs. And the systemic factors are that increasing age is also high risk, family history, and some individuals who are of African and Caribbean origin. And does treatment of ocular hypertension prevent open angle glaucoma? Other than OHTS trial, a lot of authors have worked on this. They found, many of them found there is no protective effect on further glaucoma development, but there are few authors who also found that it is protective in many of them. But some studies who told that no, have varying endpoints, and there are some limitations in their study. So we are, by far we go by OHTS trial. And there is a new method to assess who are at risk for glaucoma based on the OHTS. We have a star scaling, where a scoring tool for assessing risk. So in this scale is an example where we have to enter the patient's age, untreated intraocular pressure of 3 recordings, corneal thickness, vertical CD ratio, and pattern standard deviation. With these records of right eye and left eye, the system will give us the risk factor, the percentage, 16.9% in this patient. So based on this, we have a risk calculation that if the percentage is less than 5% on the risk scale, then we need to observe. If it is 5 to 15% score, then we have to consider treatment based on other factors. If it is more than 15%, like the previous patient had 16.9, so we definitely have to treat. This gives one assessment when to start the treatment. So before treating, we should know that we are really done all the proper investigations in this patient, like IOP, gonioscopy, optic nerve, visual field, and corneal pachymetry, because the very definition revolves around this. A proper IOP by appellation has to be done to establish the baseline IOP, and also we have to have a diurnal variation, because we should not start the treatment based on a single IOP, which can be misleading. Also, CCT has to be assessed, and we have to correct it for the IOP. Around 540 is the zero range. From above thinner corneas, we have to reduce it, increase the IOP by about 20. For every 20 micron thin, we have to add 1 millimeter of mercury, and for every 20 micron thickness, we reduce by about 1 millimeter of mercury of the IOP. And also, we should also see the angle assessment, as Dr. Mulde nicely told. Are we dealing with any angle closure patients? So we have to carefully see through a slit lamp, and of course, gonioscopy. In some situations, you can resort to UBM also to see the angle. We are not dealing with any angle closure paper because it does not fit into the OHTS category. Then the disc evaluation has to be done properly to carefully look for any notches or any RNFL defects. And this is one classically we should see that the cup looks deeper, but the eye isn't rule is being followed. So the rim is healthy and it doesn't have any RNFL part or the notching kind of a thing. It is very important to even record optic nerve diagrams so that we can really have a good follow-up of these patients. Not to forget RNFL defects. Only in undilated patients we tend to miss the RNFL defects. See this case with the red-free photograph, there are no RNFL defects, but a similar cup we have in another patient, but there is a very classical wedge defect on a red-free photograph. So just the cup looks the same, but there is definitely RNFL defect. So dilate and have a red-free photograph or red-free on the slit lamp. Don't forget to pick up any hemorrhages on the disc. Although the cup looks the normal, but there can be hemorrhages. One more risk factor, which is commonly seen in NPG and diabetic patients, not to miss the RNFL. Now, visual fields also has to be done. So these fields may appear abnormal, but we should have a reproducible fields over a period of time, like at least 2 reproducible visual fields. Consistency is very important here. Here is another case with 41 years with IOP of 27. CCT is 610, thick, then 0.3:1. Just if you go by the IOP and correct it to the CCT, it will come down to 22 or so. So it will come into ocular hypertension part. Another case is case number 3 with IOP 23, but the CCT is thin and the optic nerve is normal, fields are normal. So it's one more case with a thinner cornea, but the pressures are on a slightly higher side. Here it comes to around 25 or 26. We should look at the cups, which is the larger cups, but the healthy looking NRR. So they are also normal. And here we have a deeper looking cup with a laminar visible, laminar dot sign, but NRR is quite healthy. Here we have right and left eye. When we have a cup is big, the disc itself is big on the right and the left is disc is less, but overall cup disc ratio remains the same around 0.6, but the NRR is healthy. Here we have a typical tilted disc or oblique insertion, typically seen in case of high myopes or any high refractive errors. So you should be very careful not to look at the color, see that the subtle changes in the margins where the vessels bend. We have to have a close follow-up in such cases. Now here is one case, we just picked up visual fields. The patient came for only field testing because a lot of patients come referred from here and there. They just say, just do the fields and just tell me whether the glaucoma is there or not, or what should be done, or treat not to be treated. So we have to correlate clinically. She's an old lady which is uncooperative on visual fields. When we check these fundus, you can see only 0.3 to 0.4 CDR and a very healthy looking NRR. And just we have to repeat the test and then follow it up. Here is the case where there is a notch and a classical field changes are there. So we have to correlate the findings from the investigative modalities. So here also patient came with a printout of this inferior notch, and there is RNF, so there is RNFL defect here in the OCT. But once if we center it properly, that defect disappears. So assessing the investigative results also is very important and correlating clinically. This is another interesting case where our postgraduate has just without dilating just checked this 60 years male, 20 IOP with watering, and the right eye almost 0.4 around and the left eye almost 0.4. Fields are almost normal. The OCT is also almost normal, except there are some artifacts here and there. And then when we dilate and then carefully take the red-free photographs, you can see a small notch here and the small wedge-shaped RNFL defects in the right eye and a small area of defects in the left eye also. So this case warrants treatment, but it does not fit into the ocular hypertension study part, because there is always typical RNFL defects. What I mean to say is just don't don't focus only on the disc, just look beyond the disc on a dilated pupil and also red-free photographs. Follow-up is most important. This case has been followed up a medical student with me from 0.5 to 0.6 around, like with normal pressures around 18 to 22, it's hovering around, family history is positive. In such cases where the OCT is slightly on a healthier side, like 580 for us, so we have to carefully follow up with the photographs or a disc diagrams in every year. Then do a regular field tests in the right eye and left eye. 2011, 2012 is normal. Again next year is normal. Another year. So almost 5 years been doing without any changes. And also now we are adding on to the OCT. OHTS did not touch on OCT. Now we have OCT and other investigative modalities where the progression has already been evaluated, but it does not show any progression. Dr. Sati is going to touch upon the progression part in detail in the next talk. So the patient has to be followed up, especially when the patient is young and there is a high index of suspicion. The probable diagnosis here is for this patient is a physiological cup possibly, and we are keeping upon regular follow-up. To summarize, so ocular hypertension mainly revolves around the pressure. So the pressure less than 24, we need to observe. If it is 24 to 29, it's again question mark. Then more than 30 is a very clear cut, we have to treat. Now coming to how to resolve this question mark in this mid-range. So we have to look into the risk factors here. So the age is a risk factor, family history, initial IOP which is high, corneal thickness if it is thin, or patient profile, if the patient cannot follow up and other issues, then we have to take off this question mark and place the patient on a treatment handle. So this question mark can be resolved based on the other parameters on a case-to-case basis. So ocular hypertension with high risk for progression has to be treated, and especially one-eyed patients err on the side of treatment. Unreliable patients who doesn't give good history or compliance is poor or they travel for a long distance, unable to do reliable fields also can be an indication, and in whom optic disc cannot be visualized for some reasons, then you can err on the side of treating the patient. A patient who prefers to be treated, many times a very questionable, a lot of patients come with previously being treated, whether to remove him from the medicines or not. It's a very tricky situation. We have to assess the patient profile and then proceed with the treatment part. And treat only patients at high risk. Others, we have to have regular follow-ups. Then follow up with IOP, optic nerve head evaluation, visual field monitoring at every visit. Of course, gonioscopy also has to be done, as has been addressed before. Make use of recent investigative tools whenever you have suspicion to pick up any early warning signs of progression or the initiation of glaucoma. Correlate digital images with clinical findings, which is very important. Many times digital images can have some errors or artifacts, so don't miss the clinical findings. Assess life expectancy and drug tolerability before starting treatment. Many times a young older patients and a borderline, we can always ask him to follow up if the patient can be intolerable to any drugs. And counsel patients and keep them in the loop in the treatment protocol. Tell them that this is a situation which needs a constant follow-up. If required, we may have to start treatment early also, depending on the risk profile. Thank you. If there are any other questions, we can keep it to the end, or we can have one or two questions. Meanwhile, the next speaker is, Dr. Sati Devi. She is a senior consultant head of glaucoma at Narayana Netralaya 1, and she will be speaking on detecting glaucoma progression. Very interesting topic. So I have started the treatment now. She will start seeing whether how it is progressing. Over to Dr. Sati Devi, please.
The recorded video is there?
Yeah, Dr.
Yes,
Saul,
doctor.
please play it.
A very good morning, one and all. At the outset, I would like to thank Dr. Elin and the entire team at KOS for giving me this opportunity to present here today. I would be talking about progression. Progression is one of the most important aspects in assessing progression is one of the important aspects in managing the patient with glaucoma. At each follow-up, we need to try and see whether the patient is remaining stable or not. So when we try to assess progression, we look at three things. One is the intraocular pressure, we look at the optic nerve head, and we look at the visual fields. Optic nerve head assessment is done both clinically as well as using imaging techniques. This functional loss on the visual field and structural changes that we see during a visit are compared with baseline measurements to look for progression. Now, coming to intraocular pressure, we understand that progression can occur at what we call normal intraocular pressure levels. And so depending on perimetry alone is not a very good idea to look for progression. However, higher intraocular pressure and greater fluctuation in the intraocular pressures are definitely known to be risk factors for progression. For structural assessment, when we look at the optic nerve head, having pictures of the disc when the patient presented a couple of years back to what you're seeing now and comparing the two gives us an idea of what is happening at the disc. It would be ideal for us to have color photographs, stereoscopic disc photographs. However, if you don't have this, even simple representative hand drawings can help in assessing for progression. Also, one needs to look for disc hemorrhages and areas of beta zones of peripapillary atrophy, which are again known risk factors for progression. Now, coming to visual fields, when we look at computer-assisted progression, we look at two things. One is the event-based and one is the trend-based analysis. So what do we actually mean by this? When we talk about a trend analysis, we are looking at the rate of change of a particular measurement. It could be a VFI, it could be the VFI is the visual field index or the mean deviation. Now, these values have a direct relationship to the glaucomatous damage. So when you have longer follow-up, this kind of a trend analysis is useful. So here you can see the VFI plotted over a period of time, and you see that there is a downward trend, and then one can calculate the rate of progression. Now, this is a patient. These are the baseline fields in 2007 and 2008, and this is the field in 2018. And you can see that if the visual field index is plotted over a period of time, you see that it's extremely stable with almost no change. The rate of progression here is 0. I'm sure all of us would love to have patients like this. This is what we call the trend analysis. So here there is almost no rate of progression. When we look at event analysis, you try to set a particular criteria and say that if this particular event were to occur, and once the threshold amount of change what you have determined has been crossed as compared to the baseline, then you label that field as having progressed. So here we are detecting progression, and this is useful early in the follow-up when you may not have too many fields. So you could say that you could define 3 points that have worsened over 5 decibels or 10 decibels, and then you look to see whether this particular change has happened or not. So for example, in this field here, this I already told you is the trend analysis. But what we see as compared to these two baselines, we see that these are the values that seem to be progressing over a period of time. So the open triangle, single open triangles show that one visual field follow-up, there is progression. And on the second one, you see a half open triangle, and a fully solid black triangle represents that the worsening is seen on 3 consecutive fields. So if more than 3 locations or equal to 3 locations progress on 2 consecutive fields, then it is labeled as possible progression, which is what we're seeing here. Or if you see it over 3 consecutive fields, it is labeled as likely progression. And here you're also seeing the rate of progression, which is quite high. You see this is minus 5.3. If you have an MD rate of minus 1 decibel per year, or a visual field index rate of minus 3% per year, these indicate fast progression. The same patient had disc hemorrhage like this, and over a period of time, the disc has progressed. So you're seeing structural change also. Now, it's also important to have good baseline data when we need to compare. For example, in this patient here, this is a 2007 field on the top and 2014 below. Now, when the patient progressed between 2007 and 14, glaucoma surgery was done and the patient actually stabilized following that. However, we have used 2007 and 14 fields, and so what happens, the likely progression is seen as per the computer analysis. So it's important that we establish a new baseline. So here I have taken 2012 and 2014 as the baseline, and so there is no progression that is detected. So after surgery or any therapeutic intervention, you have to establish a new baseline. Also, test performance has to be good. So this field has been performed just 15 days apart, and it almost appears as if the fields are very rapidly progressing. However, it was just that the patient was in panic mode. She had been told that she's losing vision due to glaucoma, but this is the disc appearance. So there's no way that this disc appearance correlates with the field that we're seeing. Reassure the patient, tell her to perform the test once again that she's not losing vision, and this is the field that we see now. So you must ensure that the test performance is good, and then this can be used as a baseline. Of course, objective measurements like this NFL analysis do tell us that the nerve is definitely not showing advanced change. Now this field here appeared to show a lot of worse values all over the field. However, a careful clinical examination showed that the patient actually had a PCO pacification, and post-YAC caps, you can see that the fields have significantly improved. Now, this patient had a dense superior arcuate defect due to glaucoma. One-eyed patient, he presented with a drop in the vision and ongoing fields. This was the field that we saw. However, the pressures were well controlled. His disc also appeared stable, so it was confusing. And then on eliciting history, the patient had a stroke. So this was actually a right-sided hemianopic field defect that was superimposed on the glaucoma that was pre-existing. So remember that other things can cause field defects, neurological changes, and other changes. Now, this patient, we can see the right eye and the left eye over a period of time, definite progression that we are seeing in both eyes. Is this glaucoma, rapidly progressing glaucoma? No. We need to remember that there are again retinal changes that can also show field changes. So this lady actually had rod cone dystrophy, and the fields were progressing because of the retinal changes. Coming to progression on imaging, we do see a lot of similar to what we have on the fields. We do have computerized analysis on imaging also, which takes baseline measurements and compares it over a period of time. You can get the average NFL thickness, superior, inferior thickness, and these are analyzed over a period of time. We do see a lot of positive or a lot of progression on this imaging, but as on today, we are still not sure how much credit we can give to this change. Is it just variability over a period of time? One needs to be careful in interpreting. It would be ideal for us if we can see structural change, as in this patient, where you can see a NFL defect that is thin here, and over a period of time, the defect has definitely become wider. The fields, which was normal earlier, has slowly progressed over a period of time, and you can see that there is thinning, which has also increased over a period of time. So you're seeing structural, functional, and imaging changes over a period of time. So to conclude, clinical decisions should never be driven by perimetry or imaging results alone. A combination of a complete ophthalmic examination, which would include the intraocular pressure measurement and a detailed evaluation of the disc, including assessment of the nerve fiber layer, the neuroretinal rim, looking for disc hemorrhages, and then look at the rest of the eye. Is there a PCO? Was a laser done, PRP done between the two visits? Did the patient develop a vein occlusion? Has his cataract progressed? All this must be assessed before looking for progression. And then you correlate this with the perimetry and the NFL imaging. So you're looking at the structure and function. And then finally, look at the patient as a whole. Has he developed a stroke? Has he had a tumor? This would be the best approach when monitoring for progression. Thank you.
Thank you, Dr. Sati. It was a wonderful presentation. And also, as experienced speaker, you also did not exceed the time. You are well within that time. And one more small thing is that a lot of patients are not cooperative on visual fields. So it's a very well-established progression is there with on visual perimetry. But can we have any other assessment, like, we have a disc drawing and all, other ways of assessing progression, other than fields?
Yeah, so like I was saying, we can also definitely look at the intraocular pressure, the clinical assessment of the optic nerve head itself, and we also have the objective measurements like imaging techniques. So all these can be put together, and then you need to take a call whether there is progression that's happening. So even if the patient does not do tests very well, you do not necessarily have to totally ignore all the data that is there. Many times, especially when the patient has advanced visual field loss, it is not possible for them to do the test very well. So you can still give some credit to the field. Of course, you keep at the back of your mind that the test performance has not been good, then look at all these other parameters and then take a clinical decision.
True. Yeah. Dr. Murli, Dr. Devang, any other, Dr. Sriram, any other suggestions or?
Yeah, I think very nicely presented by Dr. Sati, and I think clearly mentioned that the OCT is also useful, but perimetry would all probably give more importance to perimetry because well-established technology and so on. But do pay attention to the other details like clinical evaluation, the disc, and the OCT. Put everything together in perspective. With regards to progression, we have seen many patients, like she mentioned in the last slide, that we notice a sudden deterioration in any patient who has been stable for many years. Then we have to look for some acute episode, like maybe an ischemic optic neuropathy or a stroke or something else which affects the patient. And do not assume that the sudden drop in field, a sudden drop in the apparent glaucoma condition is due to the glaucoma itself. We need to really look at neurological causes, vascular causes, and so on. It has happened so many times that there's a vascular occlusion or there could be a neurological problems. So this has to be kept in mind. If there's a sudden change in the patient's condition, then you should keep other non-glaucomatous causes in mind and don't assume that everything is progression.
Yeah, correct. Dr. Sriram?
Yes.
She has very well covered everything, so I don't think you have to do anything.
Yeah.
The visual field, as she said, in advanced glaucoma, many times patient may not be able to do the fields properly because the area of seeing and the area of non-seeing nearly may overlap each other. That could be the reason why. So we have to look into clinical picture also while looking at the field progression.
Okay. Now we will move on to the next speaker, Dr. Vikram Jain. He is a senior glaucoma consultant at Udupi at Prasad Netralaya. He'll be speaking on anti-metabolites in glaucoma. It's one more interesting topic. So over to Dr. Vikram Jain, please.
Yeah, thank you. Saujanya, I think you have the recording, right? You can play the
Yes,
recording.
doctor, I'm sharing.
Good morning. I'm Dr. Vikram Jain. I'll be talking about anti-metabolites in glaucoma surgery. So, scarring is the number one enemy of a glaucoma surgeon. Scarring in the region of the scleral flap and the subconjunctival area lead to failure of bleb in the long term. Anti-metabolites are used to inhibit the natural healing response, which causes failure of the bleb. These antimetabolites suppress proliferation of cells, mainly fibroblasts. Mitomycin C and 5-fluorouracil are the two most commonly used antimetabolites. They are a class of anti-cancer drugs. They are structurally similar to the natural purine or pyrimidines, which are required to carry out the metabolic reactions. They hence interfere with synthesis of DNA and RNA. Mitomycin C is an antibiotic isolated from Streptomyces species. It inhibits DNA synthesis and crosslinks the DNA, thus inhibiting mitosis and protein synthesis. It also has an action on the microvascular endothelial cells, and it inhibits this one, and hence you get these thin avascular blebs after usage of mitomycin C. Over 5FU, the advantage of mitomycin C is that it is not cell cycle dependent. It affects all phases of the cell cycle. Dosage used is 0.2 to 0.4 milligram per ml. Cellulose sponge is soaked in a solution containing this mitomycin C of the required dose and then placed under the tenons on top of the sclera. Exposure time varies between 2 to 4 minutes. Coming to 5-fluorouracil, it is a pyrimidine analog. It inhibits thymidylate synthetase and its incorporation in RNA and DNA. Hence, it causes imbalanced DNA growth and cell death, and also retardation of RNA synthesis. With antimetabolites, common complications that are seen are corneal epithelial defects if the cornea is exposed to the antimetabolite, post-op wound leak from between the conjunctiva and the corneal edge, thin cystic blebs seen, which can lead to blebitis, late onset endophthalmitis, and chronic hypotony. So here you have a thin avascular bleb which can lead to blebitis or endophthalmitis in the long run. Here you have a positive cerebral stress leakage at the junction of the conjunctiva and the cornea. So basically what we have done is, from the usual ring of steel forming, with usage of antimetabolites, we have gone to thin avascular blebs, which can lead to these complications. To prevent such complications, you should use multiple small sponges, and a fornix based flap is also very useful. I will show one video before we proceed. So instead of using a large single sponge, which can lead to these complications that I've already discussed, we should aim to form a shallow diffuse bleb by using multiple small sponges. Keep a close count as to how many so that you can retrieve all of them. So multiple small sponges over a large diffuse treatment area. Make sure that the cut edge of the conjunctiva is not exposed to mitomycin. After around 3 minutes, the ideal time, remove everything and do a copious irrigation. By doing so, you can get this ideal bleb which is shallow and diffuse. Risk factors for scarring were classified by the Moorfields group as high, intermediate, and low, and they had advocated usage of antimetabolites for the high and the intermediate risk categories. High risk categories for scarring and bleb failure are neovascular glaucoma, chronic uveitis, chronic conjunctival inflammation, and previously failed TRABs. Intermediate risk were patients on chronic topical therapy, combined surgeries, as well as previous conjunctival surgery. In most of our practices, we have moved on to using mitomycin C for each and every case, but we have to be very careful as to not give rise to these thin avascular blebs. Things which we can control are the concentration that we used. I already mentioned that it should be between 0.2 to 0.4 milligrams, by using small sponges as demonstrated in the video. Duration of application 3 minutes is ideal. Anything beyond that gives rise to these thin avascular blebs, which can give rise to late post-operative complications. And do a thorough copious irrigation of the entire this one once you remove the cellulose sponges. Adjuvant therapy post-operatively, when you see impending bleb failure, that is, you see the microcysts are decreasing, the bleb height is getting lower, you know that the bleb is going for failure. At that time, you can use subconjunctival 5-FU on a daily basis for around a week. It inhibits the fibrosis that you are going to be seeing. Or you can combine this adjuvant therapy at the time of needling. So that is in brief about antimetabolites and glaucoma. Thank you.
Thank you, Dr. Vikram. It was a wonderful presentation, and you also stuck to the time very well. And we received, we can see other panelists are entering in, Dr. Bhattu sir, Dr. Mahesh, and all from neuro-ophthalmology. Just we will take just 2-3 minutes to wind up the session, sir. Now you explained about the antimetabolites. See, there are so many other complications related to antimetabolites. Are there any alternatives to this one? Is it Olagen or some other things which are there, which you have thought of?
The Olagen is definitely there, the wound modulator, which keeps the conjunctiva away from the sclera until it gets absorbed. So in that immediate post-op period, since the conjunctiva is held apart from the sclera, the fibrosis between the two is reduced with Olagen. Since the topic was antimetabolites, I didn't include Olagen in this.
Correct. That's right. I'm just telling, Dr. Sati, any experience on replacing antimetabolites from any other better alternative you have seen because of this problem?
No, so I do use Olagen, though not as a routine, routinely, but I like to use it with a low dose of mitomycin. So if I use only Olagen, the amount of scarring is quite a bit, and I don't get very good results. So in uveitic eyes or high myopes where I'm worried about using the mitomycin, I use an extremely low dose of mito and then use the Olagen, and that has been comfortable. I have been able to get good results with that. So that's something I use.
Yeah, one is Ologen, or you can reduce the dosage of mitomycin and the duration of mitomycin also, if you think
Yes, both.
there is some worrying aspect. Dr. Murli sir, any other thoughts?
Yeah, one quick point is I think excellent talk and nice discussion. I think the only thing I would add is I sometimes use injectable mitomycin during the surgery. I use a very low dose injectable mitomycin pre-operatively or just before the surgery, and because it gives a nice diffuse area of the bleb elevation, the conjunctival elevation, and then I proceed as usual. So we know exactly how much mitomycin we are given as a subconjunctival injection. There have been some publications on that. Our data is also going to be published shortly. I think the results are similar, but I think that's another alternative.
Yeah, Dr. Devang, any other thoughts? Last thoughts?
I,
The talks.
apart like anti fibroblastic agents are important, and again in our hands, Ologen also we are not using as a primary, only where the sclera is very thin, or there we are using Ologen if required. And as Dr. Murli had suggested, that we can also use an fixed dose where we know that that much amount of mitomycin has been used, that can help in preventing these overhanging or avascular cystic blebs.
Okay, Dr. Sriram sir, any last thoughts?
I basically use only 0.2%, and I use low concentration, and I use in all my cases, but I titrate the number of time I take. Either I take 1 minute or 3 minutes depending upon the requirement. But I never use 0.4. I always only 0.2 only I always use. Ologen I use it in few cases, but I'm more prefer to use mitomycin C.
Okay. So thank you. So are there any important questions need to be asked to the panelists? There are 2-3 questions which are already asked to the panelists, and they are told in their talks itself. So with this, I think we conclude the session. I thank our external speakers, Dr. Murli Ariga, Dr. Devang Ammu, and of course our own faculty, Dr. Sriram Ramlingam, Dr. Sati Devi, Dr. Vikram, to actively participate and spending their time. I'll thank Dr. Ilan and the KOS Scientific Committee to give this opportunity. I hand over this session to the next speakers. Dr. Bhatta sir, the stage is all yours. Thank you all. Thank you, one and all.
Thank you.
Thank you.
Thank you, everyone.